Thank you. And I'll start by apologizing as I have a very strong accent and I feel quite overwhelmed by the quality of the presentation and the nice kind of sort of story running through, starting with Mark, useful introduction to sort of big data and how that can help us sort of make sense of what happens in clinical practice, in clinical work, what are some of the most common multi-morbid disorders, how we define them. There's an issue in terms of are we simply counting multi-morbidity? Are we looking at some of the underlying pathological mechanisms that might be sort of helping us to sort of frame multi-morbidity in terms of discordant or concordant multi-morbidities? Should we sort of redefine disorder simply just by looking at the pathological mechanism that may underlie disorder? Should we take into account patients sort of aspect relating to multi-morbidity in terms of quality of life and how that impact on their well-being and social functioning, as Sasha nicely sort of introduced her work in terms of what matters to patients, specifically with specific at-risk group of people that maybe they tend to be quite ignored from research. How can we bring this group of patients into research? How can we sort of facilitate those group of patients' participation in research? And so, because it's quite helpful to sort of conduct interviews, try to identify what are the sort of most common problems experienced by a specific group of people. But we know that those are exactly the group of people that tend to sort of be less represented in research and clinical practice. So it's quite interesting to think in terms of, and how can we help them with polypharmacy? How can we help them better manage the fact? And I suppose in a way, what I'm trying to get at is trying to kind of think in terms of what kind of additional investments in terms of both research and clinical practice we need. What is the main message? I suppose, and Mark pays, I apologize if I misunderstood your presentation, it was a cross-sectional or longitudinal thing. So the issue in terms of we need prospective study to try to follow up over time how this multimorbidity develop and what is the impact at different time points on an individual sort of life, both from a practitioner and from an individual point of view, and which Maria rightly suggested a life course perspective, and try to bring in terms of risk factors and how does mental health fit in. I have issues with Mark, but we're going to talk about after the session in terms of depression, mental health. We know that some of these disorders, they tend to set in quite early in life, so sometimes during teenagers, adolescence or so. I suppose that the multimorbidity and so on is going to be influenced in terms of the specific age groups which we focus on in our research. So I think we do this sort of both psychosocial aspect, as Maria suggested, and life course perspective in terms to better understand in terms of what are some of the main determinants of risk factors and how different sort of clinical guidelines also can then support patients or participants with multimorbidity in terms of both preventing but also alleviating some of the major concerns these people have. So I'll open, the discussion. I apologize because this is kind of self-focused conversation, but I'll open to everyone to sort of maybe think in terms of different areas, different questions that you might have that maybe we can discuss during this brief sort of session. Thank you.
Hi, I've got a question about the Lambeth data study that you presented earlier. Firstly, can I understand whether deprivation index is the same as the quintiles in terms of trying to define how deprived or poor people are? Is that the same definition, deprivation index or quintiles? You divided some of your patients into quintiles. Is that the same thing?
It's the deprivation index. Thank you. It is, as you rightly say, it is the national way of classifying social deprivation using the Index of Multiple Deprivation, the IMD 2015, and that comes up with all sorts of scores which are cryptically numbered 0 to about 47, or is it 48 and a half? So we just divided that into quintiles. So a fifth of the population were in the most deprived areas, a fifth were in the least deprived, and there were 3/5 in between. So we just divided the whole population into fifths.
Thank you. So I think my second question is, so those people in Lambeth divided into quintiles will mean that they have equal opportunity to services in healthcare. And therefore there are differences in how some have got multiple long-term diseases and some don't, and some, I think there was a slide towards the end where the white population had more of a problem with drinking. Sorry if I'm putting that wrong. Whereas there were some slides where the black community had more problems with cardiac disease and things like that. So my question is, they have the same equal of opportunity based on the quintiles. Is ethnicity or inequality the explanation for the differences in their health problems?
This is exactly what we are going to look at in future work. So is there a huge mismatch between access to healthcare and need for healthcare? And I strongly suspect there is. So those most deprived quintiles where most of the morbidity, the multi-morbidity clusters, do they really have the same access to GP healthcare, to community services, to secondary care? Are they always stuck with pitching up at A&E? I don't know, but that's exactly what we've got to look at, because I have a strong suspicion that the areas where health need is least is exactly the area which places most demands upon primary and secondary care services. I suspect there is a mismatch out there. Let's go out there and prove it.
Thank you.
I think she had a hand up first, but also.
Mine's a bit of a follow-up, because I was thinking that until you adjust mutually for deprivation and ethnicity and whatever else you can, you don't really know. You know, it could be that the deprivation explains most of the ethnic differences, or it could be vice versa, or there might be additional contribution of ethnicity over and above the social deprivation. So until you sort of adjust for each other, that's going to be difficult to pick apart. But my question is, would you then advocate, and this goes to the other speakers as well, channeling resources towards, for instance, diabetes prevention or diabetes management, if you see that as the starting point for so many other additional comorbidities?
Two very brief responses to your question. The first about diabetes. There is now a national diabetes prevention scheme. It's targeted at everybody who is, quotes, diabetes at risk or has got pre-diabetes, and it's being evaluated at present. It's actually been outsourced to private companies, and the initial evaluations are remarkably successful. So it really does look like the interventions to prevent diabetes at a community level could be very successful. It's early days yet, the jury is out, but my cynicism was, well, there's not much you can do to prevent progression unless society changes and we change our attitude to fast food, to obesity, and all the healthy living things. Somebody referred to exercise previously. Until society changes, you are stuck with sky-high rates of diabetes ever increasing. The second answer to your question is a really important one about this very conference to do with inequalities, that if we simply focus on ethnicity, we can unwittingly end up showing that there is less of a gap, that there's less of a problem in ethnic minority groups than we had thought. And that's because the two groups are not comparable. One can say, well, there's less disease than we had expected in the black community because the black community, by and large, is a younger age group than the white community. So if you're going to do any comparisons, a simple comparison between the black community and the white community is not comparing like with like. You have to then go on and do the statistical analysis, which involves regression modelling, where you adjust for age differences, you adjust for gender differences, for deprivation, for everything, and suddenly you see a much wider gap when you do that between the white and the black population than appears when you simply compare two groups which, at its simplest, have very different mean ages, in Lambeth anyway.
Another question for you, Mark. Your risk factors, your long-term people all live in a sort of bi-directional risk factor matrix. Take dementia alone, almost all of the other LTCs are risk factors for it, and that I'm surprised at how little multi-morbidity. You're 5% for two of those conditions, less than 2%. And I wonder if somehow conditions are being under-ascertained in Lambeth.
Big problem with primary care data sets, there is always under-recording. That estimated prevalence based on community surveys is always much higher than recorded prevalence. So you are absolutely right. I tried to overcome that in one of the slides, showing the true rate of hypertension, which was much higher than the GP recorded rate of hypertension. But yes, when you look at GP data, you end up getting a rather sanitized version of the truth and the severity of conditions out there. We did only have 1.7% of multi-morbidity because we had such a tight definition of multi-morbidity. A better figure is that a fifth of the population out there have got one or more serious long-term conditions.
Yeah, sorry, I just wanted to go back to the previous point again, to do with Mark's study. I was very interested that deprivation didn't seem to make much difference within ethnic groups, whereas we would have thought with multi-morbidity that those kind of socioeconomic factors would play a major role. But I was worried that you used the term deprivation and there are different levels of deprivation when actually you're talking about neighbourhoods and you're talking about quite a broad definition of a neighbourhood. And it could simply be that given the complexities of the way different social groups are organised in London, that actually you're not properly representing deprivation among those ethnic groups. Just because you live in one neighbourhood that might be near some luxury housing doesn't mean that you're not in a deprived area. So it's a mistake to say they're a deprived group or not deprived because they're in that particular census unit.
Again, really important point, and for the purposes of this conference, to the previous question, I said the effects of ethnicity may be underestimated because of the way we have done our calculations. Similarly, the effects of deprivation are definitely underestimated because of the way we measure deprivation. We measure it in lower layer super output areas. There are on average 1,500 people in each super output area, and as a result, the pockets of extreme deprivation get missed out, they get hidden because they're grouped together with some other areas which have got much less deprivation within that super output area. So you may have the worst council estate, most deprived area in Lambeth side by side with a few posh squares, and the next you know that the deprivation level for the whole area has been falsely elevated because of that cheek by jowl existence, and you failed to spot the true effect of really bad deprivation.
Yeah, it sounds like a small point, but in London
Yeah, we need patient level data, not area level data, this lower super output area. And the trouble is we can't get hold of it because of the anonymisation process. We are not allowed access to anything down to a more granular level for risk of re-identification. And we haven't talked about information governance to do with the data we hold, but it's a huge issue for me that data, particularly with GDPR, needs to be so watertight, secure, safe, that it does prevent some of the more detailed analyses which really could show up the health inequalities, but we can't do it. But maybe that's a good lead on to the qualitative studies and ethnographic studies, because the ethnography can get to places that statistics cannot reach. That's a bit of a lead on to Maria, maybe.
Thank you, Mark. I was going to point if you have any question for Sasha or Maria. Yeah, kind of so smart. In terms of Sasha, some interesting thoughts in terms of specific athletes. What? Yeah, sorry. Oh, it's myself, sorry. Yes. Yeah, so if anyone has any question for Sasha or Maria, which I've... yes? Please.
Thank you. I just wondered during your work whether anything came out around people's experiences or preparation for transition between services, so specialised children's services for mental health, such as CAMS, or children's social care, where, so it kind of links to your point around connection and wanting to see the same person. And there's a lot of support with some of those services, particularly with CAMS, and transition from that to more general adult services, and also transition from supported education for people with coexisting learning disabilities and mental health issues, transition from that day-to-day education to the kind of wider world. If there were anything came out around that sort of thing.
Not in the actual focus group itself, but beforehand we met a mother and her son, who I think had just turned 19, so come out of CAMS and into the adult part of mental health support and learning disabilities. And she was just saying there was just a lot less support, and she was exhausted already, and it had only been like maximum a year. So that CAMS was great and there was everything, and then suddenly it stopped and there was very little. And knowing where to find what support there was really hard for her. And I think she had some learning disabilities herself, so she was a carer and also needed support caring and for herself. So that was an insight that we weren't expecting to get and wasn't really our focus, but then was a really big valid point.
Yeah, it's just I'm working with someone in Lambeth at the moment, and we're looking at whether there's an appetite to look at transition from young people's services into adult services and what impact that might have.
Yeah, I think there's probably a negative impact most of the time, it seems, which is not here.
Another question? I have one, Sasha. Just the last, well, not the last time. From your qualitative interviews, have you identified any sort of information or data that you feel might be of help for us to consider in the future, for instance, with MARC type of big data that we could include, or maybe we could find of help from a sort of both policy and research perspective?
I think it is making space to hear everybody's voices, or at least some people's voices, because we often make assumptions about everybody, about what they need and what they want and how they behave already. And actually, like a lot of the service users that we spoke to, they knew what help they needed, but they didn't know how to get it. So giving them the space to say, actually, this is what I need, was something that was really valuable, that they're not stupid. They just need help with the day-to-day living sometimes, and they know what they need, but if they can't access it, then they have to do something else. So, yeah.
Okay, thank you very much. We're a bit late, but thank you so much for attending and participating in the discussion and listening to our presenters. Thank you so much to our presenters for some really interesting insights into the really complicated world of multi-morbidity. Thank you for joining us, and there are some really interesting sessions starting now in all of the other rooms, so I hope to see you there.